Welcome to a latest edition of Leadership and Culture in Healthcare. We are in our series 7 on clinical leadership. What is clinical leadership? What does it do within healthcare? And we have one of the national stars, indeed, influencer of the year, no doubt, from the CSP, which you're going to have to explain to us, Karen Poole from the Sussex World. Karen, welcome to the podcast. Why don't you tell everybody why you are the influencer of the year, but more importantly, what's your clinical role and what do you get up to?
Lovely. So first of all, thank you, Matthew, for inviting me to be here on the podcast with you. It's a real genuine honour. So thank you. So hi, everybody. As Matthew said, my name is Karen Poole. I am currently an allied health professions rehabilitation consultant. So what does that mean? So I'm a physiotherapist by discipline. So when I'm clinically practicing, I refer to myself as a physiotherapy consultant, but in my strategic and in my transformational roles, I describe myself as an allied health professions rehabilitation consultant. So as a consultant, it means I'm clinically practicing at a consultant level. So that means that I consult across pathways about patient care, and I work, across those systems to be able to influence for change. So coming into that influencer of the year bit that you just described there, Matthew. So really working to try and advocate, I guess, generally around patient care, but also around the services and how we design them and fit for the future so that we can get the best outcomes for our patient and our population.
Great. And so just so people listening may not know this, I probably don't know all the detail, but how does one become a AHP rehabilitation consultant? What's the trajectory? How does one get there?
So I think there isn't one clear path, if I'm honest, Matthew. I've been a consultant since 2018, and I guess just to give your listeners a bit of an idea of my journey. So I trained back in 1994. I trained in London. I was a neurophysiotherapist, so a physiotherapist specialising in neurological treatment and management. And then I moved down to Sussex in about 2003, and I came down as what they called a clinical specialist. So I guess in old money, that might be your advanced practitioner of the day. So leading, clinical teams, leading clinical care, and really kind of innovating, I guess, around some of that more localized support for patients. And then I did a bit of a sideways move. I moved into being an allied health professions lead for an organisation. So that was thinking about how do we support our allied health professions workforce within an organisation. So thinking about, workforce models, thinking about supervision, and just really trying to support the models of workforce within an organisation. And I always remember that my boss at the time said, "Do you know what, Karen? This would be a really good thing for you to do." It felt very different for me, Matthew, because this was moving away from my clinical why. Why was I here? Why was I a physiotherapist? But she said, "Do you know what? You've got some reach here. You'll have a seat at the table." In terms of that corporate seat to start to be able to influence. So I'm going to try to pull together that influencing piece and the consultant piece here. And so through that, we started to be able to advocate for rehabilitation. So through that position, I was able to start to say, look, as an organisation, we can do more around rehabilitation. We can start to develop those pathways into the community in a much stronger way. And it was through that actually almost that role as a consultant, if you like, started to emerge and started to be something that we were working towards, not necessarily just for me, but for the organisation starting to describe that as a role. So I guess for me, it was more of a process about what was the gap. So within the organisation that I work for at the moment, we don't have any rehabilitation medicine, for example. So there was, in terms of that clinical leadership, there wasn't that senior voice to advocate for rehabilitation in its broadest sense of the word. So hence the rehabilitation consultant allied health profession role became an opportunity. But for others, and it's funny enough, it was something we've been discussing this week through the CSP is, what are those formal routes really for allied health professions consultants? So there are definitely some emerging pathways. So we talked about apprenticeships. So how do we ready our workforce to move into those consultant roles for allied health professions? You don't suddenly wake up one day and you're a consultant. You need to grow into that, as you do for medicine, as you do for anything else. But we don't have perhaps the strongest structures around that part of the highest clinical leadership pathway within allied health professions. There are a few routes emerging. And I think they've been some through NHS England, so that really supported pathway. But that's been quite few and far between. So lots of us who are consultants have gone via different routes. I guess back in the early 2000s, when the musculoskeletal rehab consultants started to emerge, and they were very much designed by a commissioning route. So we knew that we needed to improve those pathways around musculoskeletal, support GPs, and we put them in via the commissioning routes. But actually, there are a huge variety of other consultant roles across the allied health professions. And I guess there's such a huge variation. So it is an opportunity, I guess, Matthew, for us to really think about how are we succession planning and how are we supporting our workforce and our future workforce to move into some of these pivotal roles.
And that's actually quite peculiar in one respect that I can think, it's very well defined how one becomes a medical consultant. I think it's actually pretty well defined how one becomes a nursing consultant. There's advanced practice, there's a ruler. I mean, this allied health professionals is what the third biggest workforce, and not having that defined seems to me. Oh, I use the word peculiar, but it is, isn't it? It's quite bizarre that that's not clear.
Yeah, so we definitely have those clear routes for advanced practice, but
Yeah.
from advanced practice to consultant isn't necessarily an automatic step. So there's something about the variety of roles that are available. So we need to be working with provider organisations and with systems to start to see the value of consultant allied health professionals leadership is one thing, but then making that leap rather from advanced practice to consultant, that's where the gap is in terms of supporting and having a really clear framework. So we have we have the consultant framework for allied health professions. So we've definitely got the framework there, but it's how do we pragmatically, absolutely. So how do we pragmatically support people? So there are some of, as I said, there are some of those pathways that have been tested. In fact, I've got consultant colleagues who've been on that NHSE pathway from advanced practice to consultant leadership. That wasn't in place when I became a consultant. That wasn't an opportunity. So actually there is definitely something about the learning from that around that really supported pathway for leadership. So the framework's there, we have advanced practice, but we've still got a little bit of a gap of how we really support that to be in place. And I guess some of that, Matthew, probably comes down to the fact that our organisations, our systems thinking about where they're putting consultant AHP leadership in. So because if there isn't the roles for people to move into, then we're not ever going to have a really clear pathway in terms of pragmatics of how we enable those people to get there, which we do for advanced practice. We have the master's routes, but again, it very much comes down to, do those roles exist for advanced practice? So you're almost a little bit stuck between a rock and a hard place at the moment. You need the roles to be there to enable the route to go forward.
You've just said that you lead in the kind of organizational approach to AHP leadership, which, as you were saying, is much more of a kind of structured corporate kind of role. What made you then think actually the consultant clinical role is one that I'd go to, even though you'd probably been, I'm sure you would have been the right person because you'd been designing to that place. But I imagine there must have been a choice at that point to say, no, I'm going to go down that route rather than stay where I am.
Yeah, absolutely. And I really enjoyed and valued my time as an AHP lead for an organisation. It was a huge learning curve for me, Matthew, and I think my manager absolutely could see that there was something about building on my clinical skills with some of that more corporate and strategic exposure to ready me into perhaps that next step. But I guess in terms for me is it comes back to my why. So I am a clinician at heart, and everything that I do is around advocating and championing for rehabilitation, for patient care, but also for my colleagues that work within rehabilitation. Absolutely want to equally advocate for them. And whilst that AHP job was brilliant, I knew that longer term, I still had more work that I needed to do around that clinical interface, about the clinical design of services, about challenging how we were doing things, what we were doing, and how we could innovate more within that space. So I guess for me, it comes back to my why, as to why I really feel that the clinical route was the right one for me.
So let's dig into that, because I'm intrigued on that. This is at the heart of this series. Is you would have been in that role the senior viewed AHP leader in the organization. Admittedly, I'm sure that means you were covering dietetics for children all the way through to adults neurorehabilitation and everything in between. So it was a wide family. But some would sit in and say, well, surely that's the most influential AHP role that you could have. And it was interesting that you decided to become the consultant clinician, because you've just described really important things of making clinical change and interactions to benefit the patient. So I'm sure both roles are influential, but why is the clinical leader role that much more influential for you?
So I think you're right. So the AHP lead roles absolutely across the country are hugely influential, because they are the ones that will interface, I guess, within whichever that part of that corporate environment they're in. So within a provider or within a system. So they absolutely have that voice. But I guess as an AHP lead, you have such a broad portfolio, such such an intense portfolio, that you're not there delivering the clinical care with patients. And for me, so one of the things that I talk about, if we talk about what's my leadership style and what I think is important, for me it is about being integrated within the area that you're trying to understand, where the opportunities are to improve the pathway of care, or to improve those outcomes. So it's kind of walking the walk and talking the talk, if you like, in being within those services. And actually, I really enjoy giving clinical care. That is something that gets me out of bed in the morning. That's the bit that I really, really enjoy. But you need to be in it to be able to see where those opportunities are. And our senior AHP colleagues across the country may not have quite that luxury within their portfolio. So I very much, within my day-to-day role, I very much use my AHP leadership colleagues and my community divisional leadership colleagues as the voice. I talk quite a lot when I'm talking to people about the key importance of enablers, that recognizing that sometimes your voice might not be the right one to be heard, but actually what I feel my value is about really understanding, getting really into the detail about how we can understand and redesign our services for patients. And that's by being in it, being working. So I've, this morning I was at the rehabilitation unit where I work. We were seeing patients and talking to patients. And so I'm there and I'm absorbing what that looks like, as well as listening to how we can really transform, I guess, and innovate within rehabilitation. And that's not me. That's listening to the voices of my colleagues. They're the really powerful people, are the people that are really helping to shape it and giving me that really rich feedback about what we need to do. So it's about using both things, I think, is for me, it's about being in there, being able to shape it, having my clinician's hat on to bring that credibility to what we're describing. But actually, I also really value my AHP leadership and community divisional colleagues, because they're the ones that will be, talking to the board, talking with commissioners as well. So it's a two-way partnership, I guess,
Mm.
Matthew.
And you work in stroke care, in neurological, get my words out, rehab, and it's a complex area. That must be multi-professional. That must have a cadre of AHPs. It must have nursing, medical,
Mhm.
psychology, pharmacology, et cetera, et cetera. The list must go on. So how does the clinical leadership role as your AHP leadership role as a consultant then dovetail with all the other clinical leaders? Give us a kind of view about how that works, because that might be quite different than people would expect, say, just in an acute realm.
Yeah. So it was really interesting. I had a conversation with a medical colleague this morning. We talked very much about the same thing. So when I talk about distributed leadership, Matthew. So this isn't about, there's often a misconception as a consultant AHP or as a consultant nurse that we're trying to be a medic. We're not. We're just being consultants within our field of practice. And so, when our patients are complex, particularly when we're looking at community patients, coming out of acute, they're complex. There's complex compound needs with these patients. And it's about bringing the skills, bringing the insights, bringing the clinical view from a multi-professional perspective. And actually we all play our part, but it's about how you work together. And I can give you a really fabulous example that's just we had a few weeks ago. We had a lady whose needs were incredibly complex, from a posture, from a spasticity perspective, from a tone perspective, a feeding perspective, a pain perspective, you name it. It was complex. This was a lady who was sitting in an acute hospital. And actually, what we did is to support this lady, we brought together neurology, we brought together pain management, we brought together anesthetics, we brought together therapy, and that was physiotherapy, dietetics. And this was a lady that we worked together with a bespoke approach for this lady, bringing on that. And it was all senior clinical leads supporting this lady. And we managed to move her care from being completely in bed in a really poor state, in incredible pain. We took her into theatre, we used botulinum toxin, and actually this lady left hospital seated. And that's about how you work together. This wasn't about one profession leading the care. This was about true integrated distributed leadership. And therefore, when that works well, that's when we really see these amazing and fabulous outcomes for our patients. So for me, that distributed approach, Matthew, is always key. There's always going to be one professional group that's going to need to step forward at one particular time, depending on what the focus and the priority is for patient care. But it's pulling on all of those strengths. So for me, one of the key things about how we work in clinical leadership is through that relationship building, through networking, through professional respect and trust, because that's really where we start to deliver really brilliant patient care.
And yeah, a really good example. And that sounds like you were all, from the community perspective and the acute perspective, working together to get the best out of that, irrespective of where the person was. Therefore, drilling back into the role, I mean, interesting, you centered on it being AHP rehabilitation consultant. So whilst you are a physio, is the difference in your consultant role is that you are leading all AHPs, or do people view you definitely as the physio consultant?
So it's a really interesting discussion to have. So when I became the rehabilitation consultant for the organisation that I work within, I was really conscious that there was only this one role. And therefore, in terms of that ability to influence, that ability to have that reach, the ability to have a voice within an organization, I purposely chose to take on an AHP descriptor of my role, because I wanted to ensure that it wasn't only physiotherapy's voice that was being heard from a clinical perspective. This was about ensuring I was advocating for rehabilitation. So when I'm talking, the speciality that I talk from is rehabilitation. as opposed to being a physiotherapist. When I'm clinically practicing, so when I
Yeah.
see a patient, I say to them, hello, my name is Karen and I'm a physiotherapist. Because that's what I'm doing. When I'm clinically practicing, I'm practicing as a physiotherapist. But when I'm not with a patient and we're looking at innovation and transformation around clinical pathways of care, when I'm describing in my strategic role within NHS Sussex, or when I'm describing to our organisation about how we could change the care pathways, how we could improve outcomes for patients, I'm coming at that from an AHP because I'm wanting to advocate on behalf of all of my rehabilitation colleagues. And that doesn't matter whether they're a nurse, a medic, I'm advocating broadly, but my background is as an AHP. So that's the distinction that I make. It's about who I'm talking to and the context we're talking in. Otherwise, there is a risk that as a if I only ever badge myself as a physiotherapy consultant in the way that I work and practice, and this will be different from others, is that there's a risk that the only voice that was ever heard was of a physiotherapist.
Yeah.
So many people, when I'm in my strategic roles, Matthew, unless I overtly sell them that I'm a physiotherapist or they know, it doesn't come up because I'm not talking about one profession. I'm talking about pathways of care. I'm talking about design models of how we deliver care within the community or within our acute.
And the mischievous side of me, which comes out far too often and gets me into trouble, but I'm sitting here thinking, I wonder whether actually AHP trained professionals are just generally better at doing that collective leadership as opposed to maybe medics of rehabilitation or nurse consultants of rehabilitation, because that's the nature of the training. Do you think that's harsh, or do you think there's some truth in that? Because it's interesting. If I was talking to a medical consultant of rehabilitation, which there are lots out and about and know many, my sense would be their ability to talk about that cross multi-professionalism is probably less than you as a AHP leader.
So,
Now, I will get lots of nasty comments for that, but I wonder if it is something about the nature of AHPs.
I think there's probably something
You're going to be very
around.
diplomatic now. I
I
can
am
see
going to be
you
very
breathing heavily.
diplomatic.
Yes.
I am going to be diplomatic, as is my way always. So I think there's something around a lack of knowledge about allied health professions anyway.
Mm.
And we're smaller disciplines, as you said at the beginning of this conversation. Whilst collectively we are the third largest workforce within the NHS, individually across those number of professions we're quite small. So in terms of trying to represent that voice, I think there is something around that AHP leadership. And actually, whilst we are distinct professions with distinct training and distinct clinical skills, there is a commonality around what we are trying to do for patients in terms of that rehabilitation in its broadest sense of the word. And so, our medical colleagues, and actually most of my medical colleagues that work in rehabilitation, are hugely pro the MDT, because I think you can't be, if you go into rehabilitation, that's almost, a raison d'etre as to why you're in rehabilitation is about that broader multi-professional team. And when we're rehabilitating patients, you can't be an isolated island around this. You can only do this if we work together, as that orchestra coming together to support our patients. So I would say probably not. I don't think I would say it's just that actually as AHPs, we are very good at working together, because that's almost, we need each other. We really value and see how much we need each other. So, as a physiotherapist, if I go back to what I do, in terms of that rehabilitation, I cannot do my job and make somebody better, improve, without the occupational therapist, without the speech therapist, without the dietitian, and I can't do it without my medical colleagues, and I can't do it without my nursing colleagues. We are in that together. But in terms of that rehabilitative recovery, there is definitely something about an integration of the AHPs together.
Maybe onto safer ground that won't get me hated by some people out there, but let's talk about how you've learned to be that clinical leader, because I can just hear it in your voice, and it's, clear in your passion, Karen, is, this is a role that makes change. And how have you been molded to do that? Where's your influence come to be that type of leader?
Yeah. So I guess when I talk to people, and often I talk to people about how you get to be in the kind of roles that I'm in, I would say not to underestimate the impact of other key enablers along your pathway. So I feel that I have been really fortunate that there have been people that have championed me to enable me to have a platform to be a leader. Um, and it shouldn't, I agree, it shouldn't always be down to individuals to do that. We should have a much better structured way of being able to do that. But actually, it is about those key enablers, which I hope I am for other people now, and I can think really clearly. So one of the first strategic roles I had back in 2014 was I was the director of major trauma rehabilitation as the major trauma pathway started to come into being. And I remember there were many AHPs taking up those roles. There were a few, but not many, because actually, often when those job descriptions first went out, they were very much lensed towards a medical colleague to
Mm.
taking up those roles, particularly when we think about trauma. Trauma is a very potentially medically dominated front door pathway if we think about it. And certainly at that time, I think things have definitely changed since then, and we've learned so much more. And I remember we had within our organisation, we developed a trauma committee as an organisation so that we could feed into the major trauma work. And this was before I was the trauma director. And I remember one of my medical colleagues that I worked with, he was like, you should be doing this role. You're describing all of this at an organizational level. Why are you not doing that? And I was like, well, no, I don't really feel that it's for me. And, a little bit, imposter syndrome. And he was like, come on, he said, who else is going to do it? Step forward, do it. So I did. And that was probably a pivotal moment, I think, for me, Matthew, in terms of that leadership journey, is that was my first strategic role. It was my first platform to have a reach beyond an organization. And whilst absolutely terrifying to do to begin with, I'd gone from working just within an organization, it was nice and safe, and to suddenly step into this role. But actually, again, it was all about those colleagues that I worked with within the trauma program, hugely enabling. And from that, I was then asked to say, well, actually, could you step into the stroke leadership role for the system? Oh, okay. Well, let's do that then. And again, key enabling people within that. I remember our one of our clinical directors within NHS Sussex. One of the issues that I had was that the stroke pathway is brilliant. It has so much strong evidence, a strong structured pathway, but there is a risk. There was a risk that actually we end up advocating and supporting a stroke pathway at the detriment of people with other similar needs. And for me, that was where that journey around needs-led rehabilitation absolutely started. And I voiced those concerns and I said, look, this is great. I think, this is a really powerful platform for us in terms of stroke, but how do we use that to support a wider group of our population? And it was this clinical director that said, do you know what, let's develop a rehabilitation mandate for Sussex. Let's develop this that's using all of that rich learning from stroke, all of that amazing evidence that the stroke pathway have developed. And it has been such an enabler, the stroke pathway. But let's make this much broader. So that was the first start. We developed that for Sussex. And then since that point, I've moved into a couple of other clinical director roles within NH Sussex. And the culmination, I guess, of that, Matthew, is that we have just completed a huge transformational piece of work within Sussex. We've undertaken a major service redesign, and we've done it for our neighbourhoods, for our urgent and emergency care. But for the first time, rehabilitation and intermediate care were level pegging up there with urgent and emergency care. That is not what happens in all systems. Rehabilitation is usually the poor relation, end of the pathway, poor relation. It's in the community, it's poorly understood. But actually, through this enablement of all of these key colleagues to help lift up and get me to a platform, we've then been able to have a voice along with others, it's not just me, about being able to get the rehabilitation on the sheet for a major service redesign, which is huge.
And so that sounds like truly helpful and supported leaders, some who have probably pushed you out of your comfort zone and encouraged you to do other things. And have you sought out people to be kind of formal mentors or coaches to you? Because those those are some really tough environments to be leading in. You do things nationally, you're in front of, parliamentary panels, you're doing things all over the place, Karen. How have you personally found ways to kind of refine your leadership?
So I guess in multiple different ways, I would say, Matthew. So um, I've definitely sought out mentors at various points. So for example, with the major service redesign work, that felt like another big step and a big leap in my leadership journey, being co-chair with a colleague for that piece of work. I mean, it was huge. And actually during that time, I sought mentorship from the chair of NHS Sussex, and that was hugely valuable, gave me so much learning in terms of how do you chair some big stuff.
Mm.
So that was really helpful. But I guess lots of mentorship. Um, I seek advice from peers as well. I developed, so when I first, sort of those early years when I was in a consultant role, I felt quite lost, if I'm honest, particularly as a rehabilitation AHP consultant. There were lots of people working in the musculoskeletal field, and there were much fewer number of us
Mm.
working in broader fields like rehabilitation or frailty. And so I sought out colleagues, and we, across the country, and I still, we still reach out now, and a number of us have been consultants for many years. But that was really important, that peer support, that, are we doing the right thing? How have you tackled this? What have you done over here? Can we work together? Can we share? So for me, that networking is absolutely critical. In terms of, filling up your bucket, I think, really, Matthew, in making you feel that you're not an imposter, that you're not going off in the wrong direction, that you're working in similar ways. And it isn't about making a carbon copy of everyone, but it is absolutely about, you know, helping you to grow. So the peer leadership and the mentoring, absolutely important. And then I guess it's about seeking out those internal supports, so your day-to-day supports, and that isn't about people necessarily above you. So that's about my colleagues, particularly my advanced practice colleagues that I work really closely with. I bounce ideas off. I don't, just because
Mm.
I'm the consultant doesn't mean I have the best idea in the room. In fact, most of the time I really don't have the best idea in the room. But really, bouncing off one another, really generating those ideas and that passion. And it's passion, I guess, that probably drives me.
I was going to drill into that for our final set of quick kind of discussions, because you ooze passion, about getting this right and doing this with people and doing it in that wonderful cultural style. What kind of helps you to sustain that? Because life's tough. All the pressures clinically, the responsibility you got, the money never stacks up, ever increasing complexity in the stroke world. You're looking after people with far higher levels of complexity and dependency, given the success of thrombectomy and other kind of processes and treatments in hospital now. So, what keeps you going, Karen, to kind of be that beacon?
So a couple of things probably. So I think first and foremost is that absolute joy when you see patients getting the right care. So for me, I guess the first and foremost things is absolutely that patient getting what they need from us. So really knowing that the work has been worth it, that the blood, sweat and tears of getting the right pathway or the right care in place, or even just delivering that right treatment, is absolutely critical. I think seeing my colleagues thrive, um, there's nothing better than seeing your colleagues that you've been mentoring, you've been supporting, and that's at all levels. That isn't just people that are in advanced practice, really thriving, really kind of taking flight, becoming really autonomous. And what I mean by that, I don't mean in terms of autonomous practice. Obviously, as AHPs, we have that autonomous practice, but that real freedom to act, that real kind of, actually, I've got this, we can do this. And then almost going further than I've gone in terms of developing something, that cultural innovation, that innovation in terms of how we deliver care to patients. We've started with a seedling over here, and look how much it's grown. That absolutely brings me joy. And then just seeing how our services are moving. So something I used to have. So when I first became a consultant, I went over to work in intermediate care, so in a rehabilitation unit, and we had a lot of work to do within that space. We had a lot of work to do to help others outside of the unit understand what it was we were doing and why we were doing it. And also there was a real opportunity for us to want to innovate. And what I had in front of me is I think and work out loud, Matthew. So in the wall in front of me in my desk, I used to just write on a post-it note and stick these random things on the wall of things that I'd thought about, either just like, we need to do this and we need to do that and we need to do the other. And I remember sometimes when that going is really, really tough and you think, oh, we're not making any progress, and you're not seeing those outcomes that are lovely on a paper that you can say, oh, look, and this is our progress, and look at how our activities improved. Because sometimes there's a lag with that. But actually what I could see is I looked at that post-it note wall and I ticked through. One day I went through and I ticked all of the things that we had done. And there was something like 3/4 and more of the things that we'd achieved. And there were small things. It was things like, does the reception area look welcoming? Have we got a volunteer on the reception desk? These weren't big things, but actually building up that level and sharing it back to staff. They're the things where I think I go home at the end of the day and I think we are making a difference. And that for me is what's important.
I do a non-sticky note when I walk the dogs, but I have to remember to write it down nowadays. And I have to say, my team regularly say, "Would you stop walking your dogs?" Because then you keep on coming back with stuff that lands on us. But it sounds like your board is the same. So here's one last thing to probe, then, Karen. What one thing are you looking? You sound like you're looking forward to lots of things, but when you look at 10-year plan, when you look at the shifts, analog, digital, all the government priorities, what would you kind of hone that down to? What are you really looking forward to getting your teeth into over the next kind of months and years to really make that change? Is there something specific that kind of sits on? Is there the big post-it note that's sitting there going, that's what I want to be able to tick off?
So I think for me, this is about, so we have a methodology in Sussex that we have adopted through the major service redesign work, and that is that all care should be needs-led, it should be proportionate, and it should be tiered matched. So I guess my one desert island disc wish would be that all of our services are able to use that methodology, so that what we can do is provide the care, particularly in the community, but not just our community, in our acute hospitals as well, that we can provide the right care responsively to the right amount for an individual person based on their needs. So that's the one thing that I really want us to see over the next few years, because from that will lead so much innovation in terms of how we deliver rehabilitation across our pathways.
And I guess quite a lot more out-of-bedded care and into people's own
Entirely.
homes to recover as well.
Entirely. Yep.
Yeah, which
Absolutely.
is just really crucial, isn't it? Karen, it's been fascinating listening to you. AHP Rehabilitation Consultant since 2018, just the massive amounts of work you've done in leading organizations in terms of AHP, I think that really important element of making sure we're all clear about how people can move from expert practice, advanced practice into consultant levels, whatever the professional group, because they're really important. And that shift to you're a clinician at heart, I love that phrase, and that guides everything that you are doing. And I think people will hear in droves about just the right leadership credentials, the ability to convene, the ability to make change, and actually, from a clinical leadership role, actually sort out the detail that makes it so much better for the individuals to get great care. And you've just been talking about, your full desire to make sure that that happens every single time with every single person, which is a really impressive ambition, isn't it, for everybody in Sussex. Makes me want to go and live down there in case I need those services in the long-term future, no doubt. Given I have friends who live down there, they will, I'm sure, benefit from your approach. Karen, it's been a delight listening to you. Thank you for joining me on leadership and culture in healthcare. We wish you well as you go for those big, stick note kind of moments and tick them off day by day and week by week. Thank you.
Lovely. Thanks, Matthew.